reduction, or safer options? So the question is, and it's a question I'm putting to you tonight, are we keeping up with the way tobacco use is changing? So today, patients are not only smoking cigarettes, and in fact, smokeless tobacco is consumed by more than 360 million people in 140 countries, and usage is increasing. I saw some stats from the UK that shows that vaping now supersedes smoking in the youth in the UK. These products are marketed as safer, cleaner, smoke-free, tobacco-free. But guys, let's be clear. Safer does not mean safe. The WHO theme challenges all of us to look at the way that these products are appealing. We're seeing that they're flavors that attract younger users. Candy floss, butterscotch, ice cream, sleek modern packaging. I've already told you that some of the vapes, they've got unicorns on them. I mean, what adult man is going to buy a vape that has a unicorn on it and is pink? It's aimed at the youth. There's lifestyle branding. They talk about nicotine pouches being discreet, so you can use them and nobody even knows. So it really is concerning as well that a lot of the messaging is around harm reduction. Now, this can be true if you're going from cigarettes to, for instance, vapes or smokeless tobacco. But we're finding that people are starting with these products now. So this messaging is not accidental. It's intentional design to sustain and expand nicotine addiction. And we need to remember that all of these alternatives are being marketed and funded by tobacco companies. So let's have a look at the different types of alternate tobacco or nicotine supply. The first one would be the e-cigarettes, vapes. They're also called nicotine ENDS, electronic nicotine delivery systems. They produce an inhaled aerosol. They are promoted as safer or harm reduction. They have appealing flavors, discrete designs, many different strengths of nicotine. But guys, they are not risk-free, and the long-term ill effects are still emerging. Those that we know about include asthma exacerbations, particularly in the youth population, chronic bronchitis symptoms and dry cough, risk of myocardial infarction, and in fact, we are seeing more and more admissions to emergency centers where patients think they're having a heart attack, but in fact, it is nicotine toxicity. Unlike a cigarette where you smoke one cigarette and you're done, you can suck on a vape the whole day and you don't realize how much nicotine you're actually taking in. On top of that, there is still periodontal disease and caries, and there is second-hand exposure, which is linked to asthma and bronchitis in the people that are breathing the vapor in as second-hand. Then we go to the heated tobacco products. They're also known as heat, not burn. Here, a tobacco stick, specially made, is heated and it produces a vapor. Again, marketed as reduced exposure. And again, not risk-free, and long-term effects are still emerging. The known health risks at this stage are that they are carcinogenic. There is an acute impact on pulmonary systems, including oxygen saturation levels and airway function. It affects the cardiovascular system, and there is an impairment of the vascular endothelial system. It's linked to an increase in respiratory infections and asthma. Next, smokeless tobacco. So this is tobacco that is sucked or chewed or sniffed. It is actually tobacco leaf. Again, it is marketed as being safer because you don't inhale any smoke. But there are health risks. It is strongly associated with oral, esophageal, and pancreatic cancer. It causes gum disease, tooth decay, and tooth loss with continued use. There is a high nicotine exposure, often equal to or even greater than that from cigarettes. And there's an increased risk of heart disease and stroke. The contain nicotine but no tobacco leaf. They are considered new, modern, and discreet. The health risks here in particular are nicotine addiction. These pouches come in different strengths, going right up to 16 milligrams per pouch. This is particularly concerning for adolescents who can pop one into their mouth and you wouldn't even know they've got one and that they're using them. Its use has been linked to increased risk of cardiovascular disease, esophageal, oral and rectal cancer, obesity, type 2 diabetes, and heart failure. They contain certain harmful heavy metals and flavoring agents which are linked to severe periodontal disease via a toxic response in the gingiva. They are harmful to the periodontal innate immune response, and there is a significant increase in all-cause mortality. Water pipe or hookah has been around for a while, and this is often perceived as socially acceptable and less harmful. After all, you're bubbling the smoke through water, surely that's filtering it. And unfortunately, hookah exposes users to substantial toxins. One session can deliver smoke equivalent to many cigarettes. There are high levels of carbon monoxide, heavy metals, and carcinogens in that vapor. There's an increased risk of lung cancer, cardiovascular disease, and other cancers. There's a risk of infectious disease transmission because mouthpieces are shared. So here we think of Hep B and herpes. So rather than focusing on each product in isolation, let's simplify. What do all nicotine products have in common? They deliver nicotine, which is associated with addiction. They reinforce behavioral dependence, and many expose users to toxic substances. The key clinical message here is that no nicotine product is harmless. There are certain population groups that are particularly at risk, and they warrant special attention. The first one is young people and adolescents. So we all know from research that nicotine affects brain development in the young and the adolescents, young adults. But there's also pregnant patients. Nicotine is known to affect fetal development and can cause early miscarriages or premature birth. Then, of course, there's the dual users. So many users consider the fact that they are maybe cutting down on their cigarettes and using vaping in between, that this exposure will be safer. But this is not true. Even 1 to 5 cigarettes a day cause disease. Then, of course, there's the people trying to quit. And I've seen this in many instances where they move over to vaping. And unfortunately, what they do is they become addicted to the vape and they continue vaping. Lastly, patients with cardiovascular or oral disease. And that one is obvious. You saw it from the risks that I've already gone through. Dual use is especially important because patients often think they're reducing harm, but they are often prolonging exposure. So let's recap. Let's look at the global burden of tobacco. So over 7 million deaths annually are due to tobacco use. Remember, these are preventable. 1.3 million deaths are from secondhand smoke exposure. And my mum was one of those statistics. My mother never smoked a cigarette in her life. Unfortunately, my father smoked 2 packs a day for most of his life, and she died of lung cancer. Tobacco users worldwide are 1.25 billion users, and 80% of those are in low to middle income countries such as South Africa. The interesting thing is that 60% of smokers want to quit, but more than 70% of them have no access to stop smoking support. Let's have a look at the Global Adult Tobacco Survey. This one was done in South Africa in 2021. So if we have a look here, the blue is smoked tobacco, the orange is cigarettes, the gray is hookah, and the yellow is electronic cigarettes. So the first one shows overall. But what I want you to look at is the 15 to 24-year-old group. Look at that group there. We are sitting with 23, almost 24% of our 15 to 24-year-olds in South Africa smoking. This is terrible. And you can see it increases 25 to 44. We're sitting at 26.7%. And it drops off as they get older. Unfortunately, when we hit 65, around about my age group, we realize that what they've been telling us all along is true, and that smoking is not good for you. But what we are seeing, this was done in 2021, is that the vaping is going up. And remember here, we are not including nicotine pouches, and we're not including smokeless tobacco. So the prevalence of tobacco and electronic cigarette use by age among adults 15 years and older is growing. 29.4% using smoking, 41% are men, and 18% women. So what is the impact of smoking? And specifically here, I'm looking at non-communicable diseases. We know that it is a major risk factor in many non-communicable diseases, including diabetes, chronic respiratory diseases, cardiovascular disease, and cancers. And in fact, 13% of all NCD-related deaths in South Africa are attributable to tobacco use. And currently, there are more than 32,000 deaths in South Africa directly linked to smoking. That's 32,000 premature deaths that were completely preventable. Tobacco cessation significantly reduces the risk of various diseases, in particular non-communicable diseases. So let's have a look at the smoking-related deaths in South Africa. And I see some of my little windows didn't come up. But the biggest one is chronic lower respiratory diseases, where 21% of deaths are related to smoking. Heart disease, 13%, ischemic heart disease, 13%, and then we go around to the cancers and what have you. Here's just a picture. It's not pretty. Tobacco causes cancer, and none of those are a pretty picture. So what does the evidence tell us? Smoking is a real chronic disorder characterized by the development of an addiction status mainly due to the nicotine. This condition makes the smokers generally unable to quit without help. Smoking reduces the quantity and above all the quality of life. Smokers' life expectancy is on average 10 years shorter than non-smokers. How many of you are prepared to give up 10 years of your life just for nicotine? Half of the smokers lose about 20 years of healthy life before dying because of a smoke-related disease. And in fact, tobacco is the only product, when used exactly as intended, that kills half its users. So let's have a look. What is in a cigarette? What is in cigarette smoke? Well, research tells us that there's more than 4,000 different chemicals. But tonight I'm going to take you through the three main categories. And those are carbon monoxide, the volatile hydrocarbons or tar, and of course nicotine. So carbon monoxide, clear, odorless, tasteless gas. It binds to hemoglobin by attaching to the same site on the heme molecule where oxygen normally goes. But it has a much higher affinity, and this effectively displaces oxygen and prevents your blood from carrying it around the body where it's needed. And so you'll see people that smoke, if they climb stairs or do anything vigorous, they get out of air, they get out of breath very quickly. It increases plasma viscosity and fibrinogen levels, making the blood thicker and more likely to form clots. It forces the heart to work much harder, leading to cardiovascular disease. And of course, it's the smoking during pregnancy that prevents the fetus getting the oxygen it needs, leading to low birth weight and premature births. Now let's consider tar. Tar is the main carcinogenic component of tobacco smoke. And 70% of inhaled tar is retained in the lungs, where obviously it has a direct effect on lung function. You saw the photo I had earlier where the lungs are actually black from tar. It is also these hydrocarbons that have a significant effect on the metabolism of some prescribed medicines, and in particular, many of the psychiatric medicines. Interesting to note that low tar cigarettes are no safer than the higher tar cigarettes, because very often smokers compensate by smoking more frequently and inhaling more deeply when they use the low tar cigarettes. And in fact, a study by the American Cancer Society found that the use of filtered low tar cigarettes may be the cause of adenocarcinoma, a particular kind of lung cancer. The last component is the nicotine. This is a ganglionic or nicotinic cholinergic receptor agonist. It is an alkaloid found in the nightshade family of plants. It constitutes approximately 0.6 to 3% of dry weight tobacco. Widely used as an insecticide in the past, and in fact, I still use tobacco dust to keep the snails off my vegetables. In low concentrations, and remember an average cigarette yields about 1 milligram of absorbed nicotine, the substance acts as a stimulant in mammals and is one of the main factors responsible for dependence. According to the American Heart Association, nicotine addiction has historically been one of the hardest addictions to break. So this gives you an idea of how nicotine works. So you can see here, number one, you inhale the smoke. Within seconds, it travels to the brain. It attaches. It was an agonist, so it attaches to the receptors, and dopamine is released. And of course, we all know dopamine, that leads to the feeling of pleasure and calmness. But unfortunately, this is a reversible attachment, and so very quickly you get a drop in dopamine. And this leads to withdrawal, symptoms of irritability, and stress. Very often this is mistaken that you need to have another cigarette to calm you. But in fact, it is the nicotine that is causing the stress. So nicotine is highly addictive. The cigarette delivers nicotine rapidly to the brain within seconds. And the nicotine addiction involves dopamine reward pathways, withdrawal symptoms, behavioral reinforcement, and relapses, cycles. So guys, what is our role? And one of the most important interventions that I would like you to take home tonight is that it can take 30 seconds to save a life. We call it VBA, or very brief advice. It's also known as the 3 A's: ask, advise, act. 30 seconds to save a life. Ask and record tobacco use status. Advise on the most effective way of quitting, and act on the patient's response. That's it. If all you take away tonight is the VBA, then I have succeeded, because by asking, you make a difference. So what messaging should clinicians communicate to all patients? And remember, smokers expect to be asked about their smoking habits by healthcare professionals. You're not going to catch them unaware. They expect us to ask. So firstly, don't smoke. Secondly, if you do smoke, there are major health benefits to stopping as soon as possible, no matter what your age or how long you've been smoking. And thirdly, a wide array of effective cessation treatments are available. And if we as clinicians need motivation, we already know that our role is to save save lives, then let me read this to you. In fact, as smoking will cause the deaths of 50% of current smokers, and as most smoking-related illnesses are reversible, one premature death will have been avoided with every 2 smokers a clinician persuades and helps to stop smoking. So let me quantify that for you. As a clinician who motivates 10 smokers to stop smoking in a year, will have prevented 5 avoidable early deaths. Not a bad return on total investment of a few hours. Let's have a look at the relative effectiveness of different health interventions. There's something called NNT, which is basically the number needed to treat. And this is defined as the number of people who must be treated or screened for a given period to prevent an event. We all know statins. We know they work. They're prescribed regularly. As a pharmacist, I dispense statins all the time. Statins have an NNT of 60 for heart attack and 268 for stroke over 5 years. That means you need to treat 60 people, and these are adherent patients, for 5 years to prevent 1 heart attack. And you need to treat 268 people for 5 years to stop 1 stroke. Now, those statistics are considered good enough for it to be an essential medicine. When we look at cervical cancer, and hopefully all the ladies on the call tonight go regularly for cervical cancer screening, the number needed to screen is 1,140 over 10 years to prevent 1 case of cervical cancer. Let's have a look at smoking cessation now. So brief advice, VBA, 30 seconds. If you give VBA to 80 patients, you will prevent 1 premature death. Add pharmacological support to that, and it goes to between 38 to 56. Add behavioral support to that, it is 16 to 40. And then, of course, I've already said, for every 2 people that you help successfully stop smoking, you would have prevented 1 premature death. A lot of people will say to you, well, I've cut back, doc, or often they call us pharmacists doc as well. I've cut back. Well, why smoking less is not good enough? There is a clear dose-response relationship between smoking level and the risk of developing or dying from a disease. But evidence shows that as little as 1 to 5 cigarettes a day cause cardiovascular abnormalities. If we look at cancer, duration matters more than dose. So a 3 times increase in the number of cigarettes per day increases the cancer risk 3 times. But when we look at duration, a 3 times increase in the number of years that you smoke, you get 100 times the increase in the cancer risk. I'm going to spend a little bit of time on this slide, which is the stopping smoking health benefits. So guys, everybody knows smoking's bad for you. And in fact, I know that smokers get packets of cigarettes that have got black lungs on them. There are all sorts of warnings on the pack. Threatening people or telling them it's bad for them doesn't work. Rather focus on the benefits. So within 20 minutes of your last cigarette, your heart rate and blood pressure levels return to normal. 8 hours after your last cigarette, carbon monoxide starts to leave the body and oxygen levels return to normal. Within 24 hours, mucus and debris caused by smoking begin to clear out. And this is where people sometimes start coughing. And I've heard people stopping smoking say to me, I didn't cough until I stopped smoking. I'm going to start smoking again. Within 48 hours, nicotine is no longer in the body and your senses improve. That's your sense of taste, your sense of smell. Within 2 to 12 weeks, breathing improves and exercise becomes easier. 3 to 9 months, coughing and breathing problems reduce as the lungs repair themselves. And at 1 year, the risk of coronary heart disease is now 50% lower than that of a smoker. Those are the facts that you need to tell your patients. One of the other benefits, of course, is the cost. Now, very often when I recommend nicotine replacement therapy, they'll say to me, oh, it's too expensive. Then please whip out your calculator. So if somebody pays, and this was based a few years ago on a pack of 10 cigarettes, 27 Rand. Many people smoke 20 a day. That's 54 Rand a day, 378 a week, 1,620 Rand a month. The cost per year is 20 grand, and the cost over 10 years is 200,000 Rand. So I say to many of the people I help stop smoking, put your 54 Rand in a jar every single day, and then treat yourself when you've gone without a cigarette for 4 weeks. You'll have 1,620 Rand. So let's look at the evidence base for treatment options. I already showed you that of the 70% that want to stop smoking, the 30% that go on to try and stop smoking, and then you end up with a measly 3% actually getting there. Well, there's the no treatment. So no treatment, going cold turkey, even with very brief advice, you get a 3 to 5% success rate. If you take nicotine replacement therapy and the VBA, it goes up to 10%. That's a 3 times increase in success rate, not to be sniffed at. Add behavior change therapy, support, and medication, you're now looking at 20%. So if we go from the 3% to 20%, you can see the increase. Support, which combines behavior change therapy, one-on-one sessions, and medication, gives the optimum chance of successfully quitting. It triples their chances. So let's just briefly have a look at the pharmacotherapy options. So the first one, and I'm going to be expanding a bit on this, is nicotine replacement therapy. It is available as pharmacist-initiated therapy. It's Schedule 1 and Schedule 2. It is very accessible. Then we've got varenicline. So varenicline is a nicotinic agonist. It is an anti-dependence agent. It has a high affinity for nicotinic acetylcholine receptors, where it is a partial agonist. It is a Schedule 5 medication, so it requires a prescription from a doctor. And then the third one, which I'm going to very briefly touch on, is bupropion. So this is a noradrenaline dopamine reuptake inhibitor. It is actually an antidepressant, which they found helped people to stop smoking. Unfortunately, it does have a number of side effects. It is a Schedule 5 medicine and does require a prescription. This evening, I'm going to look at NRT. The other two would be for another session. So let's have a look at the relative effectiveness of the different treatment options. The graph below illustrates trends consistent with Cochrane evidence at 4 weeks post-quit. So if we have a look here, the orange is no support, and the blue, I just want you to look at the orange and the blue, is individual behavior change therapy. The green, just so that you know, is group behavior change therapy. So if we look at no support and no medication, you can see where we're sitting with the success rate at 4 weeks. So this is not continued abstinence, this would be just for 4 weeks. Add on a bit of support, goes up to 22%. But now let's look at mono nicotine replacement therapy. Adding that to no support, you go from 16% to 25%. And if we add in behavior change therapy, we're now sitting at 37%. But what I really want you to look at is the combination NRT. So this is where you combine something like a patch with gum or the mist. And have a look there, with no support, it's now 36%. That's NRT and behavior change therapy will successfully reach the 4-week post-quit marker. You can see here for bupropion, it's actually lower than combination NRT, so linked with all the side effects and contraindications. It's the reason I'm not focusing on bupropion. And then if we have a look at varenicline, which is very often considered the gold standard, you'll see that combination NRT is almost as effective as a Schedule 5 medicine. So let's continue. Nicotine in a cigarette. So a typical cigarette will have about 0.7 to 1 gram of tobacco, and it contains between 9 and 17 milligrams of nicotine. Most of this nicotine, though, is lost during the process of smoking. And if a cigarette is smoked as hard as possible, a smoker can absorb a maximum of 6 milligrams of nicotine into their system. Just thought I'd show you here that a toxic dose of nicotine is estimated to be about 60 milligrams in adults. So if somebody eats 10 cigarettes, please phone the poison center. And for children, it's 1 milligram per kilogram. Can you see the challenge here when you have these liquids for vapes coming in those wonderful flavors and fragrances like candy floss? And you can see the risk that you must tell people that vape to keep those vaping solutions away from children and babies. So let's have a look at the rates of nicotine absorption from cigarettes, cigars, and pipe. The one I want you to focus on is the cigarette, which is this line over here, the pale green. You'll see that this is the y-axis is plasma nicotine. The x-axis is time in minutes. So you smoke a cigarette and you can see a very rapid increase in the amount of nicotine in your bloodstream. It peaks at just around 10 minutes and then it very rapidly drops off. So let's have a look now why it is so hard for smokers to stop smoking. So you can see here a smoker first thing in the morning. This time the x-axis is 9 o'clock, 10 o'clock, 11 o'clock. And this is presuming somebody is smoking 1 cigarette every hour. So you'll see the very rapid rise in plasma nicotine. Then it drops off. Then they smoke another one at 10 o'clock. And what I want you to see here is that if we look at the baseline, you'll see that the baseline nicotine is increasing. Smoking is not one nicotine exposure. It is repeated nicotine dosing throughout the day, constantly reinforcing that addiction. Let's have a look at the withdrawals, because this is what happens when somebody stops smoking. So if we have a look at this table, it shows you the symptom, the cause, and the duration. So when somebody stops smoking, the first thing they're going to do is they're going to have nicotine withdrawal. They're going to have cravings. And the average person will have 3 or 4 cravings that happen for the first 2 or 3 days. The important thing here is that those cravings actually only last for about 3 minutes. And so if you can delay somebody, if they can do something for those 3 minutes, that craving doesn't last the whole day. It lasts 3 minutes. And these recur. They're frequent for the first 2 or 3 days, but they can recur for months, even years. The next one I want to look at is irritability. That can last 2 to 4 weeks. Fatigue, remember nicotine is a stimulant. That lasts about 2 to 4 weeks. Dizziness, that's an interesting one. And I've had heavy smokers that feel very dizzy when they stop smoking. And they think it's that they're going to die. But in fact, it's their body experiencing extra oxygen. It's a good thing. And it only lasts for 1 to 2 days. Insomnia. And this, coupled with varenicline, can be a real problem for people that are stopping smoking. The reason is that nicotine affects brainwave function, which influences sleeping patterns. And the insomnia from withdrawal lasts about a week. unfortunately, insomnia due to varenicline can go on. And it's important to warn people about this insomnia, because we all know that if we go without sleep for days on end, we don't have a good prognosis. Difficulty concentrating. The body needs time to adjust to not having constant nicotine stimulation. This lasts a few weeks. Depressed mood, feeling sad after quitting is common. Then, of course, there's the cough, dry throat, nasal drip, chest tightness, constipation, and hunger. So let's have a look at the various nicotine replacement therapy methods. We've got the mist, we've got gum, and we've got patches here in South Africa. If we have a look at the pharmacokinetics of these different formulations, and again here we are plotting on the y-axis plasma concentration of nicotine, and on the x-axis we've got time in minutes. Remember the cigarette peaking at around 10 minutes, and you can see there it peaks at about 25 nanograms per mil. You'll see that the one that mimics a cigarette the closest is the spray or mist. You get the high quick absorption and then the drop-off. Important to note that the spray only comes in at a much lower dose. Then if we have a look at the gum, it takes much longer to work, and it has a slow increase in plasma levels, and then it sort of tapers off. And then lastly, if we have a look at the patch, which is the dotted line, you'll see the patch takes a long time, and it just keeps a base level of nicotine in the bloodstream. But the patch is there for 16 hours, slowly releasing nicotine. Remember, people are not only addicted to the nicotine, but to the rapid spike and reward cycle created by cigarettes. But I also want you to look here and realize why gum and patches can't be used on an ad hoc basis when somebody has a craving. Because the craving that lasts 3 minutes, you'll see here, the gum will not even be in the bloodstream. And so many people will say to you, I've tried the gum before, it doesn't work. There's a reason it didn't work. It's because you were trying to use it to combat cravings, and that is not what it's intended for. So let's have a look at the science behind NRT. NRT leads to a doubling of cessation rates achieved by non-pharmacological interventions, irrespective of the level of that intervention. And combination NRT is 27% more effective than single product use. NRT and gum together has been shown to help control weight gain, often experienced after cessation. And the risk of dependence is small. In fact, it's less than 5%, unlike vaping. The long-term use of NRT is not associated with any serious harmful effects. So supporting cessation. Effective cessation includes behavioral support, pharmacotherapy, and follow-up. Combined support significantly improves success rates. The goal is not switching, the goal is complete cessation. So how do we integrate this into practice? And remember, this does not require extra time. It can be integrated into every patient interaction. Every interaction is an opportunity for VBA. So, in conclusion, tobacco and nicotine products are evolving. Marketing is driving perception, and patients are often misinformed. Our role is simple and powerful. Identify use, correct misconceptions, and support quitting. Every conversation matters. Every question matters. And every patient we help to quit is a life changed. So I put it to you now. What one question will you start asking invite Elani back.
Thank you, Jackie, and thank you for this incredibly insightful presentation. I'm sure it has been extremely valuable to our audience, and if you can see all of the hand claps and the hearts, I'm definitely sure that it has made an impact. As we move into the Q&A session for the evening, I noticed that we already have a few questions, which I am going to get right into. So the first question is, for the numbers needed to treat on smoking, over which period is it calculated? Was it 5 years or 10 years, or which period was it calculated?
So the NNT on smoking is over 5 years.
Thank you. The next question, is there any evidence of the efficacy of the cigarette butt or filters?
So whether you use a filterless or a filter cigarette, it does reduce a little bit of the tar. But at the end of the day, whether it's a lot of a carcinogen or a little bit of carcinogen, it really doesn't make that much difference. A lot of smokers say to me that the filter just makes the smoking smoother. So what you find is those that smoke cigarettes with filters smoke more. So again, and I think I alluded to it, Elani, that low tar cigarettes and even these ones that try and trap tar, you're fooling yourself. At the end of the day, cessation is the way to go. We need to get people to stop smoking.
Thank you for that, Jackie. Our next question is, how long does the behavioral change therapy take to be effective?